Hello and welcome to the ASCO Daily News Podcast. I'm your host, Dr. Monty Pal. I'm a medical oncologist, professor, and vice chair of academic affairs at the City of Hope Comprehensive Cancer Center in Los Angeles. And I have to say, there's really no margin of error when it comes to the introduction of AI in oncology. This is something we're all talking about. The clinical stakes are high. They involve sometimes toxic treatments that we use. And truly, and I don't think this is hyperbole, it's a matter of life and death under some circumstances. I think there's clear advantages to AI. I mean, clearly it can process data faster than we as humans can. And I do think that there's some potential application of this when we talk about delivering therapies to patients. But there's also this institutional risk in its use. And that is that we might actually lose some of the core competencies that we have as oncologists. Today, I'm really excited to really delve into these topics, things that, I hadn't really dwelled on, terms like de-skilling and never skilling. And for me, I've got a real expert on my hands today to really sort out this matter. It's Dr. Arturo Loaiza-Bonilla. He's the system-wide chief of hematology and oncology at St. Luke's University Health Network in Pennsylvania. He's the co-founder and chief medical officer of Artificial Intelligence of Massive Bio, a global AI platform that manages patients with clinical trials and novel therapies. Dr. Bonilla's work spans precision oncology, trial optimization, and responsible AI integration into clinical workflows. Arturo, it's so great to have you on the podcast. Thanks so much for being here.
Thanks so much, Monty. It's nice to be here too.
Indeed. And I think the last time that we saw each other, was it Advocacy Day last year?
Exactly. We always go there, talk to different lawmakers and try to bring forward the concerns of everyone here and, after priorities. So it's always good to see you in different environments.
I know. And I'm bummed out. I'm not going to make it this year, unfortunately. So I won't see you there, but I'm hoping we'll be able to catch up at an annual meeting. Just a quick note for our listeners, all of our disclosures are available in the transcripts at the end of the episode. So Arturo, let's get right into it. Why don't we? So essentially, AI comes with a load of potential benefits, but a load of potential issues. I think that one of the things that we're really worried about is what happens to good old human expertise. Can you walk us through these terms that we mentioned in the introduction, de-skilling and never skilling? What does that refer to?
Yes, and it's interesting because we're just learning how to apply these to medical oncology and to healthcare as a whole. And all of them are extremely important and they have different connotations. So the first example is de-skilling. So the skilling is basically what we call the erosion of existing expertise because we rely too much on the automation process. So imagine that you are just looking at a CAT scan as a radiologist or as an oncologist, and then you miss that gorilla in the room. So I always talk about this, what we call sustained inattentional blindness, which is that actually there was a study that showed that 83% of radiologists may miss a gorilla embedded into a CAT scan, even though their brains tells them to do so, because basically you assume that, it's nothing there. You're kind of like guided in that one direction. And something that to make sure that we don't miss that clinical expertise that we have had. We have a recent paper actually that came in Lancet Gastroenterology and Hepatology just last year. And what it showed is that when you use an AI tool to help you to do colonoscopy, that non-AI colonoscopy feature went from 28.4% to 22.4% when you don't use it. So basically, these very experienced folks doing colonoscopies, if they use the AI for a while and then try to do it on their own, they kind of lost a little bit of that skill set that they had prior. So that's a very important one that I feel we should always be on top of. So never lose that skill. The other one is never skilling. So never skilling is a high risk because those are for new things coming up. And if we rely on AI telling us exactly what that means, that's going to be a problem. So I always see it from the medical education side, medical students, residents, fellows, and even early career folks, and even for ourselves who have been in the trenches for a while. What if something else comes up and we just simply rely on the AI tool to tell us what that means? And it's just something that we just don't learn those first principles, right? Of like tumor staging, or what are the features of this, or what are the risk factors that lead to it? Like we just read it out of the output of that AI tool and never learn it. So that's a major risk because then we become extremely reliant on those platforms. The other one is misskilling, which also called as algorithm concordance, when basically the AI consistently may underestimate the risk of something happening, or it just gives you biases that are embedded into the data set and the algorithms that don't apply to you. And then we just basically follow that. And last but not least is the automation bias, which is all kind of encompassing. It makes sense. It's just a complete cognitive offload where humans just basically trust the machine, even when their own intuition tells them like, no, don't do that. So the patient may look, not sick at all, but you have a feeling that there's something happening. And that ability that comes in our minds is a very unique things to humans. We should never miss that. So automation bias is also a major risk that we need to make sure that we don't fall into.
So I'm going to get right to it because we were going to discuss this later in the podcast. But, I think we should just, address right up front how we're going to tackle these things in medical education. When you think about de-skilling, for instance, I think that maybe that's the most tangible concern here. What approaches can we take in terms of educating our residents, our fellows in the age of AI? You ask them to submit a write-up on a particular disease area and so forth, and they can generate it with AI in 2 seconds, or they can spend hours in the library doing it. What's the approach we should be taking?
It's a complex situation. I have a master's in medical education, and they never taught this to us. It was about 10 years ago when I did it. But something that we have been learning from the whole process of the implementation of AI is that we can learn from other practices. So, for example, we were recently at the conference of the National Academy of Sciences. They brought someone from Waymo. So Waymo, those fully automated cars that just simply drive you and you just trust them, sit down in the car. And even my mom, she was like super nervous. She's like, what are you doing there? Like, are you sure there's no driver there? But they have to learn to be, it's also high stakes, right? And something that they know in the algorithms is to first have to have that driver thinking, okay, is this the right suggestion that this Waymo algorithm is telling me? And yes and no, and why we should do this. So to me, it's all about making sure that we are leveraging our all intelligence. Life in this planet is unique, but our intelligence is one of a kind and something that we should always see as the highest asset in our whole lives. But it's all about thinking for a minute, having this Socratic mode, right? So let's say I'm just wondering, okay, I want to know what is the rationale for using this combination treatment. And then the AI just tells me, well, there's a phase 1 clinical trial that showed this. Like, okay, sure, great. Let me just read that information that it was given to me and apply it to the context of my patient or the question I'm doing. And that's going to help me the most, and this is common sense. But the thing is, many times we don't have the time to be thinking about, okay, let's sit down and do this analysis. But it's so important in this particular scenario where we cannot 100% trust. So there's always this pattern of trust, but verify. In AI, is always 100%. So even if the AI is giving me a good answer, I just go and look at the data source and make sure that, first of all, it's not hallucinated, because these systems actually like to do that. They like to please and give you an answer. Even if they don't have the answer, they just try to give it to you no matter what. And lastly, making sure that you're reading that in the context of the clinical question you're making, because the AI tools, they always miss context. That's the key component that we have, that the AI is going to be very difficult to do so, even in a multi-agentic system.
Yeah, it's funny because I think that you hit the nail on the head there with one particular word, and that is sources. When we think about how to teach this next generation, they could easily go to open evidence, or they can go to new ASCO platforms, in fact, and just say, okay, this is how we're going to manage a stage 1 breast cancer patient. But really understanding the source documents, as we would consider in a clinical trial, right? Where does that data actually come from is really, really key. And this kind of goes back to when we were sort of sitting around on rounds, right, as residents and fellows and so forth, where the fellow comes around and really tries to get at the root of why you've made decision X, Y, or Z. Being able to quote citation X and journal Y is really, really key. So I'm hoping the journals stick around. I'm hoping that our current clinical trial infrastructure doesn't dissipate so that we can kind of get this all, sort of moving forward. Let me kind of dive a little bit deeper into some of the other issues around AI, and that is the sort of Google Maps effect. I like the way that, it's sort of described here in our episode notes. There's this risk, I think, that we may have this heavy reliance. A doctor in the clinic may just become so tethered to any sort of AI-based platform that they just fundamentally get lost when that tool is not available. I can't think of too many scenarios where a tool wouldn't be available. Maybe there's a data outage or something, right? But how can we avert that situation? So if we do go into crisis mode, or if a doctor, heaven forbid, doesn't have those electronic tools at their disposal, they can still function.
Yeah, we have some examples. So for example, when there's a ransomware attack in the health system, right? And then they had to shut down the EMR. Then we had to learn how to put an order and how to check for labs in the system itself, because everything goes out to paper. So yeah, imagine a scenario like that, which would be in this case too. We need to have what I always think about it as a deliberate redundancy. We need to have multiple abilities to get information when this AI or whatever we're thinking is not available. So every system, including training programs or pathways programs that we have in our institutions, all of that, they should have what we call an AI off drill. So basically having a drill time when we're just trained just to see what will happen if we don't have this tool available. And it should be part of always on the emergency thing that comes up when a system fails. We do this in emergency all the time. We do these drills for fire and see where the emergencies are. Well, these are also equally as important. This is AI in healthcare. All of them have, depending on, I know AI is kind of used too broadly these days to apply to from decision support to multimodal drug discovery, which is another topic for maybe another discussion in podcast. But I think for at least clinical decision support that we have in front of us, using a platform like Open Evidence or NCCN guidelines or the ASCO guidelines or whatnot, we need to have this scaffolding where we sometimes don't use it and just go and see the data ourselves. I just came from the NCCN conference. I still rely on the NCCN looking into the pages, even though they're long and they may be a little bit overwhelming to some folks. But I teach that to my APs and my fellows in clinic. And I think it's a good exercise because it tells you the sources, the good principles you were telling as well, of how to access information and what can we do to show these patients. Because if I tell my patient, well, just Open Evidence just told me to do so, I don't think it's going to be too confident, right? So we show them the path that, the NCCN guidelines, which is how we're doing, this analysis, and showing the page that shows them the algorithm and say, this is a consensus that we have built for many years across hundreds of people working on this for many hours. That would be a better way to explain these things. Take the best of both worlds is the way that I kind of look into this Google Maps situation for the Waymo self-driving car, right?
I love the idea of like sort of a fire drill, something like that, where you just say, okay, machine's off. What would you do in this circumstance, right? It's a great way to test clinical acumen to make sure it's maintained. I mean, I'm hoping that AI can be sort of like an occasional crutch as opposed to something that we use all the time, day to day in practice. And that gets to maybe another issue, which lends itself to our reliance on AI. And that's this phenomenon of cognitive offloading, right? Yesterday, for instance, I had 33 patients in clinic. I saw 24. My APP saw 9 of them. And we were exhausted by the end of the day. There's no doubt. Like we were just, kind of thinking to ourselves, gosh, how did we do this? And we always talk about burnout, whether or not these types of careers are sort of sustainable. There might be this temptation to just say, okay, let's take these tough decisions that we have to make, how to, for instance, manage the patient that calls in asking for management of diarrhea, or the patient that calls in asking for a refill on perhaps psychiatric medications that might conflict with oncologic prescriptions. Just lean on AI to fix those problems for us. How do we avoid just over-reliance on that? Because I think that I see this phenomenon of people too often just sort of hitting the easy button there.
Yes. And actually, that's a discussion that we're having right now because we're trying to assess how to manage the volume of patients calling in during the day. We're in clinic. And I just had this discussion with my team precisely for the same reason. And as you mentioned, this is the main problem, not when we are fresh and just woke up and we're super happy, have our coffee, is when we're tired, right? Automation bias becomes super dangerous is when we really offloaded the whole thing. We're behind schedule. We're super tired. And that's what we just relying on with will alone is not enough. I think we always have to be looking into how we can protect judgment. I think that's the key way that I wanted to look into that. So one simple thing that I'm always considering is let's always force this first initial impression to be the safeguard. So let's just look real quick, even for someone answering the phone for diarrhea. Is there like a specific reason why this patient is calling? Is the patient of immune therapy? Because if a patient calling for diarrhea, it could be because they're taking irinotecan-based treatment or they may be on ipi/nivo, right? So all that can have a completely different connotation in the amount of information that we need to see. So that's the first component. Always force that, particularly for automation bias. The other one is understand the provenance of that. So if we're looking at these AI tools, once again, is this the context that the question is being asked appropriate? And what is the plan B for override? So we always have to have a human in the loop override. For example, I trust on my nurses 100%, but even when there's a simple order for medication for diarrhea, I actually co-sign it, right? So having that person is, okay, that makes sense. The system learns how we do things right, but also we need to verify that at the end. So in basic clinic is maybe tempting, but if the relief comes at the cost of like us missing a big problem, I think we need to be on the top of it. So it all depends on the use case. So if it's just to know what would be my approach, but that doesn't make a decision, that's better than when we're really making decisions that affect the patient in front of us.
That's brilliant. This has been such an amazing dialogue. And I think mainly what I've highlighted in the course of our conversation today are all the concerns that arise with AI. But I mean, clearly, probably no one knows this better than you. there's tons of potential positive applications. I mean, can you tell us some of the cool stuff that we might anticipate in the next year or two as it pertains to how we're using AI? It could be within oncology, but also radiology, genomics, et cetera.
Yeah. So now you turn on the enthusiast part of me, which is always the one you see. So AI is really a big opportunity for us to be better clinicians. So I was thinking this the Moravec's paradox, which is AI relinquishing all these things that we really feel that we don't have to do, spend time like documentation, and we actually can focus on listening. So everyone is using ambience AI, which is great, and it's a very good adoption of time. We're still trying to figure it out if it actually overcomes burnout, which is a different story. But at least for more avant-garde use cases, it's really helping us to decrease the time for, radiology reviews for mammograms. So now we have clinical trials looking for using just one readout instead of two, using AI tools. We also have the ability to detect early pancreatic cancer. I'm a GI oncologist, so I'm always trying to, how do I get my first degree members of my patients, get better screen tools? Can we now deploy an algorithm with AI that is showing that? And there's a study called Panorama that is able to prove that is able to find these things better than, our naked eyes, that sometimes we cannot really see those very small nuances. And in pathology, in areas where there's no pathologist that we can do just simply an H&E stain and tell me if the patient has an EGFR mutation or even they have high mutational burden. Just the ability for us to use simple tools that we have in our daily basis, like a single slide, but being able to upload it and give me an answer right away that can help the patient to be better treated. I think there's no better use than that for AI. And of course, clinical trial matching. We work with the American Cancer Society, and every single patient gets an AI generated report, and we're working to make it even better and larger. So to me, is every single day we're doing something different in this field, and I cannot be more excited about that. But we have to keep in mind all these risks that we have in front of us so we can be very ethical, explainable, and appropriate in the deployment of these solutions.
Indeed. No, I mean, I think this is a vexing issue, right? How to, sort of apply AI in day-to-day practice. And you've given us some of the cautionary notes, and I think you've given us some of the potential advantages. This has just been a terrific discussion. I really want to thank you for sharing your insights with us on the ASCO Daily News podcast.
Thank you so much for having me here. Looking forward to seeing everyone. And in ASCO, we'll be there for sure.
Awesome. Finally, if you value the insights you heard from today's ASCO Daily News podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.